Hello, my name is Sarah Hoffman and I am a freshman nursing student. This past semester, I had my first clinical experience at Heartland Healthcare Center. Right now, I'm going to present to you one of the patients I was able to assess and work with. Patient background and psychosocial data. My patient is a 42-year-old African American woman. She is single and prior to coming to Heartland Health Center, lived alone in her condominium. Patient grew up in Detroit, Michigan in a middle-class family and has one daughter who visits her often. Patient believes in Christ and her prayers are very important to her. Patient denies any perceived stressors. Patient is educated and works as a corporate trainer but was laid off in July 2014 and is currently unemployed. Immunizations and drug reactions and allergies. Patient is up to date and current on all immunizations and vaccines, including yearly flu vaccine. Patient allergies and drug reactions include Diamox and silicone, which induce lethargy and local edema when in contact. Past medical history. Patient has extensive past medical history. Patient diagnosed with type 1 juvenile diabetes at age 9, leading to peripheral neuropathy and onset of sarcoidosis at age 15. Patient has mild depression, hypertension, hypothyroidism, and carpal tunnel syndrome in both wrists. In addition, patient has STI, glaucoma, sickle cell anemia, arthritis, abnormal uterine bleeding, and experienced a total retinal detachment. Currently, patient is experiencing difficulty in ambulation due to neuropathy and drug interaction with diabetes. Hospitalizations and surgeries. Patient past hospitalizations include multiple hospitalizations as a child due to uncontrolled diabetes. Patient past surgeries include cesarean section for delivery of daughter and retinal reattachment surgery. Family health history. Patient has medical family history of cancer, thyroid disease, and diabetes. Mother of patient has hypertension as well as a thyroid disease. Patient's maternal grandmother had colon cancer. Maternal grandfather and paternal grandmother both had diabetes. Functional assessment. Since coming to Heartland Healthcare Center, patient has experienced a change in sleep pattern. She defines her sleep pattern as irregular and inconsistent. In addition, patient has experienced drastic weight loss since admittance into Care Health Center. Patient uses wheelchair as safety device and is currently receiving physical therapy twice daily. Patient is not a current or former smoker and does not consume alcohol. In addition, patient does not consume excessive amounts of caffeine. Vital signs and pain. Upon first examination, patient's vital signs were taken. Her blood pressure was 118/73. Her pulse rate was 76. Respirations were 16, and patient's temperature was 97.2 degrees Fahrenheit. Patient rated her current pain at a 0. Chief complaint. Patient's chief complaint is retinal detachment pressure drug interaction with diabetic diagnosis resulting in paralysis of lower extremities and overall weakness in core and upper extremities. History of present illness. The onset of patient's present illness was November 24, 2014, the day on which patient received total retinal reattachment surgery of her left eye. Post-operatively, intraocular pressure medication was administered to patient to control eye pressure and inflammation. This retinal reattachment pressure medication then interacted with the patient's known diagnosis of type 1 diabetes and resulted in paralysis symptoms of lower extremities and overall body weakness. On December 24, 2014, patient was transported from hospital to Heartland Healthcare Center for longer-term health care. The post-retinal reattachment surgery drug diagnosis interaction has rendered patient unable to move lower extremities as well as an associated symptom of increased neuropathy in lower limbs. Patient's lower extremity paralysis is constant and results in incredible interference with daily activities. Patient requires full assistance getting out of bed, bathing, and dressing, and partial assistance for toileting. Due to nature of paralysis as present illness, symptoms are not able to be aggravated or alleviated. Despite the patient's current setback, patient's perception of health is positive and hopeful. She is involved in her treatment and care and desires to gain back her lower extremity mobility. Patient is committed to physical therapy regimen, dedicated to gaining her strength back, and hopeful to eventually return home. Current medications. Due to patient's large number of diagnoses and medical needs, patient takes a great deal of daily medication. For increased healing of left eye that revealed retinal reattachment surgery, patient receives 1 drop left eye 2 times daily of both atropine 1% ophthalmic solution and dorzalamide ophthalmic solution. In addition, patient receives prednisol acetate ophthalmic suspension drops in left eye as needed for inflammation. For patient's diagnosis of diabetes, patient receives 100 unit per milliliter insulin glargine injections as needed throughout the day and 14 units into skin at bedtime. Also for her diabetes, insulin lispro 100 unit per milliliter injection 3 times daily before meals are given to patient. For patient's hypothyroidism, patient receives 1 levothyroxine 50 microgram tablet by mouth daily. In addition, patient takes 2 300 milligram gabapentin capsules 3 times daily for neuropathy symptom relief. For patient's hypertension, patient receives 100 milligram losartan tablet by mouth daily. To treat patient's depression, patient takes 25 milligram capsule of nortriptyline daily at bedtime. For sickle cell anemia, patient takes 1 iron tablet daily by mouth. To maintain overall health, patient takes a 100 unit vitamin D tablet daily, as well as a Women's Health Daily multivitamin once daily. For pain control, patient receives 500 milligram acetaminophen tablet by mouth every 6 hours as needed. 2 chosen symptoms. Upon examination of patient and given patient's health history and current health status, it became evident that the 2 symptoms of highest priority were head, ears, eyes, nose, and throat system, and the neurological system. Review of symptoms of head, ears, eyes, nose, and throat. Patient's history of total retinal detachment, surgery for retinal reattachment, and current left eye inflammation and lack of mobility caused me to select head, ears, eyes, nose, and throat as one of my focus symptoms to review and examine. Upon patient review of symptoms, patient denied history of headaches, dizziness, fainting, and facial pain. Patient has history of glaucoma and retinal detachment and has corrective contacts and glasses for vision. Patient states that she has significantly decreased vision acuity and control of left eye due to retinal surgery. Patient denies history of cataracts. Patient states hearing is acute and strong and denies history of ear infections. Patient denies history of blood or discharge from facial orifices and states that last eye and dental examinations were within the last 6 months. Patient denies history of voice hoarseness and history of colds and sore throats. Patient denies history of head trauma and concussions. Patient experiences no difficulty when swallowing and denies history of head, neck, or face radiation. Patient has rash on back of neck due to cleaning products used at facility, but denies neck pain or tenderness. Head, ears, eyes, nose, and throat physical examination. Upon physical examination, patient's skull appears round, symmetrical, and appropriate for both body size with no lumps. The skin appears clear, smooth, and normal for race. Patient eye structure is not symmetrical due to decreased left eyelid control and edema and erythema around left eye. Patient has full range of motion of neck and movement is active and controlled with no pain. Trachea and cervical vertebrae are midline with no thyroid enlargement greater than 1 centimeter. Cervical lymph nodes are palpated and are not enlarged greater than 1 centimeter and cause patient no pain upon palpation. Upon examination of eyes, left eyelashes contain yellowish clear discharge as well as left eyelid ptosis noted. Left eye conjunctiva is reddened, sclera is reddened, and cornea and iris are cloudy and misshapen and not symmetrical to right eye. Left eye does not approximate completely when closed, and surrounding skin of left eye is swollen and red. Right eye appears healthy with full approximation when closed, no redness or swelling or discharge, moist conjunctiva, skin intact, white sclera, clear and round cornea, and round iris. Palpation of lacrimal apparatus produced no secretion and did not cause patient pain. Visual acuity was not able to be tested, but suspected results would be complete left eye blindness. Testing peripheral visual fields revealed a decrease in left eye peripheral vision due to left eye blindness. Extraocular muscle function tested using 6 cardinal fields revealed a decrease in left eye movement when compared to right eye. No nystagmus was found, but tracking was not bilateral. Patient's corneal light reflex test was not a mirror image reflection due to cloudiness and edema of left eye. Cover-uncover test revealed decreased left eye control as a result of corrective measures necessary to refocus eye. Size of right and left pupils were equal. They were round, reactive to light, direct and consensually, but accommodation was not accurate in left eye. Right and left external ears were firm but movable, symmetrical, and were not swollen or painful. Hearing test was unable to be performed due to a lack of equipment and time. Romberg test checking vestibular apparatus was also not able to be conducted due to patient's lack of stability to stand. Inspection and palpation of nose revealed patent and symmetrical nares and no inflammation or lesions or bleeding. Nasal cavities were clear and moist and pink. Palpation of frontal and maxillary sinuses produced no pain or tenderness. Lips were smooth, pink, and without cracks or lesions. TMJ movement was smooth with no popping or tenderness. Buccal mucosa was pink and smooth. Teeth and gums were without decay and pink. Tongue was pink with no lesions. Soft and hard palate appeared healthy, and tonsils appeared a grade 2 with no lesions. When testing hypoglossal nerve, tongue was midline with no deviation or tremor. Glossopharyngeal and vagus nerve appeared intact as a result of rising of uvula and soft palate midline. When patient said ah. Assessment of gag reflex was not conducted. Review of systems of neurological system. Patient's current condition of lower extremity paralysis due to drug diagnosis interaction calls for a focused history review of symptoms of the neurological system. Patient denies history of seizures, strokes, and loss of consciousness. Patient has history of numbness, tingling, and burning due to diabetic symptom of neuropathy. Numbness is localized mostly to feet and hands and is worse during the morning, though constant throughout the day. Patient has no concerns about concentration ability or memory. Patient states that her sleep pattern has changed since admission to Heartland Healthcare Center, but she denies history of insomnia. Patient has constant unsteadiness and loss of coordination due to present condition of paralysis of lower extremities. Patient denies history of anxiety and difficulty with speech. Patient denies history of back or neck or head trauma. Patient denies diagnosis of Lyme's disease or meningitis. Patient denies having a family history of dementia. Patient states that she has had increased trouble with vision since retinal reattachment operation. Patient is experiencing large limitations in lower extremity gross and fine motor function due to lower extremity paralysis and body weakness. Patient reports decreased reflex response in lower and upper extremities since drug diagnosis interaction. Neurological physical examination. Assessment of patient's mental status using Folstein Mini Mental State Exam. Patient was oriented ×3 to person, place, and time. Patient stated name, birthday, year, date, and day of the week. She was oriented to state, city, and place of care. Short-term memory intact. When asked to repeat ball, cat, and roll, patient successfully repeated 3 words in one trial. Attention and calculation. Patient has full intellectual ability. Patient able to count backwards from 100 by sevens. Patient long-term memory intact. When asked to repeat 3 objects stated prior, patient quickly responded with ball, cat, roll. Language. Patient able to recognize and state objects and pencil and watch. Abstract reasoning intact. Patient able to understand and repeat no ifs, ands, or buts. 3-stage command test was not conducted due to patient's inability to perform lower extremity motor function. Patient able to read and obey command, close your eyes. Did not perform writing sentence or line, online, or copying design test due to patient lack of ambulation. Patient's total mini-mental score was 25 out of 30. Assessing patient's motor function. Due to patient's lack of ambulation, patient unable to perform gross motor and balance test of normal gait walk and tandem walk. Patient unable to perform Romberg test due to lack of ability to stand without assistance. Upper extremity fine motor function intact. Patient showed no signs of ataxic movement. Patient able to touch nose with finger with eyes open and closed. Able to touch examiner's finger and able to alternate hand movements on lap. Lower extremity fine motor function of heel to shin test was not conducted due to patient's inability to ambulate lower extremities. Assessing patient's sensory function. Patient able to sense light and painful touch on both upper and lower extremities while eyes closed. Unable to assess vibratory sensation due to a lack of tuning fork equipment. Discriminatory sensation intact. Patient able to decipher object placed in hand during stereognosis test and able to detect letter draw letter drawn on palm of hand during graphesthesia test. Patient proprioception intact when asked to state finger position as up or down. Pathological reflexes, unable to perform Babinski and ankle clonus due to patient privacy and lack of access to lower extremities. 2 other pertinent systems. In addition to head, ears, eyes, nose, and throat, and neurological systems, and based on patient's current health status, it would be important to also assess the patient's musculoskeletal system and integumentary system. Musculoskeletal system linked to neurological system. According to Seams-Donnelly's research on walking mobility in neurological disorders, it is important to assess patients' musculoskeletal system because of the lack of mobility that has been an outcome of patients' neurological motor function. Patients' inability to control lower extremity muscle function due to her lack of neurological muscle control has affected patients' ability to walk, and she requires total assistance. This lack of muscle use, noted, needs to be closely monitored for further muscle atrophy, and this can be done by assessing patients' musculoskeletal system. Integumentary system linked to neurological system. According to Margarita Lindgren's research study that confirmed immobility as a risk factor for pressure ulcer development among hospitalized patients, it is important to assess patients' integumentary system because of her increased risk for pressure ulcers due to her lack of neurological muscle function. Patients' lack of neurological motor function causes patient to be immobile and confined to a bed or chair and needing total assistance. This lack of mobility thus increases patients' risk of pressure ulcers and calls for assessment of integumentary system. Thank you for listening and for allowing me to be involved in the care of this patient.